Well, good morning, everybody, and welcome to Big Tent USA, a national women-led group that advocates for democracy through civic engagement, education, and activism. We have just 8 weeks before the critical midterm elections, so before we get started, I wanted to share our September events. Tomorrow night at 7 p.m. Eastern Time, Cecile Richards will join us. Cecile is a lifelong activist for women's rights, social and economic justice, and most recently co-founder of Supermajority, a new organization fighting for gender equity. For 12 years, Richards served as president of Planned Parenthood and is the author of bestseller Make Trouble. Next Tuesday, September 20th at 9 a.m. Eastern Time, our Tent Talk will host Keonti Stewart-Reed, Executive Director of Fair Fight, about their grassroots work in Georgia, prepping for some of the most critical midterm elections in the country. The following Tuesday, September 27th, we'll hear from Executive Director of You Can Vote, Kate Fellman, who works in North Carolina to register, educate, and mobilize voters. And to wrap up the month, on Wednesday, September 28th at 7 p.m. Eastern Time, David Pepper, author of Laboratories of Autocracy, a wake-up call from behind the front lines, will discuss how some state governments have become breeding grounds for anti-democratic policies and what can be done to stop it. If you aren't yet familiar with David, be sure to check out his very informative whiteboard talks on Twitter. And please head over to bigtentusa.org to register and request letters from Vote Writers and Vote Forward. And now we are honored to have Plan A's Dr. Caroline Weinberg and Desiree Norwood join us from Mississippi. Dr. Weinberg has been a passionate advocate for accessible healthcare as a fundamental human right. With both medical and public health degrees in hand and real-world experience in Uganda, Guatemala, and the rural US, Dr. Weinberg founded Plan A to bring healthcare directly to our underserved communities in rural America and serves as its executive director, launching its first nonprofit mobile clinic in April 2021. Desiree Norwood is Plan A's program coordinator. Caroline and Desiree, a warm welcome to Big Tent USA. My father used to often remind me, actions not words, but somehow you all have managed to do both so well. We are in awe. I was introduced to Plan A when Big Tenters gathered in DC on the Supreme Court steps during oral arguments for Dobbs, which now seems a lifetime ago. Our deepest thanks for all you do to serve our fellow Americans who have few, if any, options for healthcare. And a quick reminder to our guests to put your questions in the chat. And now let's get to it. Caroline and Desiree, tell us more about Plan A's evolution. How did you get here and where do you hope to go?
Thank you so much for that introduction and for having us, and to everyone for joining. I'm Caroline, and I'm gonna tell a little bit about kind of how I got started in this space, and then Desiree is going to talk some about her background, and we'll kind of go from there. I started Plan A in 2018, 2 days after Kavanaugh was confirmed, when I was trying to figure out kind of what to do with that level of fury, I guess, and decided to point my attention at building programs that would increase access to care in some of our most vulnerable communities. And I just remembered I forgot to share the slides. Give me 1 second. Like mid. There we go. So I decided to, the mobile clinic model is a well-proven way of increasing access to care in communities. And so I wanted to set out and do that in rural areas. And Mississippi is one of the states with like the worst healthcare outcomes and also some of the most restrictive policies on access to care. But I, as was immediately obvious when I opened my mouth, am not from Mississippi. So I went down there and kind of presented this idea to people and said, you know, I want to use a mobile clinic to increase access to reproductive health care. Do you think it would work? And I found a group of people who were incredibly enthusiastic about helping me pull it off. And I turned my attention for the first year on working really closely with the community to focus on building a community-based healthcare program that was rooted in the community we served rather than statistics, that found out what the priorities of the community were and went to bring it directly to the people where they are, addressing some of the major barriers to care that exist well, both in Mississippi, but also just broadly across the country. So that was kind of what we did what I did for the first year. And then we focused on once we were able to kind of open our doors and operationalize the program, we hired an entirely local team that focused on kind of launching and bringing the care directly to folks. We work with 2 community health workers and a nurse practitioner. And they provide the care on the clinic itself. The mobile clinic offers all forms of family planning, from condoms to long-acting reversible contraception, STD testing, HIV testing, PrEP, pap smears, mammogram referrals, and primary care screening. And we get a lot done on a 210 square foot truck. And also we have a brick and mortar clinic, which I'll tell you a bit about later, that offers primary care. So that's how I got started in Mississippi. And in this past April, Desiree joined the team as a program coordinator to help us. The way I describe her job is she makes sure that we live up to our potential as a program. So I'll let her explain kind of how she ended up with us and a little bit of what she does.
All right. Good morning. Thank you all for having us. So my story as to how I ended up with Plan A is definitely one that I don't talk a lot about, but I'm actually sometimes forced to. So I'm actually the mayor of the town of Sunflower, which is a very small town in the Mississippi Delta area. And I was introduced to Plan A by a community health worker that was interested in reaching out to communities that did not have any health care there or that did not have certain services. And once I was contacted by the community health worker to actually come to the community and provide these mobile clinics, I was enthused because I understood the plague. I understood how small communities did not have access and some of the barriers to healthcare. So just getting the opportunity to bring this service to the community that would take care of some of the barriers that were being faced in my small community, which were, access to care and also even the access to transportation, and also providing some services that you probably couldn't get not only in my community, but neighboring communities within 15 to 30 minutes. And so after confirming the mobile clinic coming to the town of Sunflower, to my community, and just seeing the amazement from the citizens, and also just seeing the impact that the mobile clinic could make, and understanding the services that they have, and also just being able to have that access was something that was very, very meaningful. And so I would actually start to have conversations with neighboring communities about the services and how they could possibly get them into their community, because during this time we're still dealing with COVID, and a lot of individuals weren't moving around, and so it was an opportunity to have those services provided to them. And after just sharing with the communities, I almost feel like I was a part of Plan A before I became a I'm sorry about the service, that I was a part of Plan A before I became a part of Plan A. And so once the opportunity came to join the team, I was enthused about joining the team, because I felt like that was a part of my purpose. I like to use public servant. You always want to make sure that you're finding ways to improve the community and the well-being of others around you. And so by being a part of Plan A, I would understand what rural communities were actually facing when it came to healthcare, and how we could definitely be a part of just providing hope and letting them know that, hey, we do have these services available and we can definitely assist you. And so now I'm here as the program coordinator. And like Caroline said, my job is to make sure that we live up to the potential. And also my job is to serve as a liaison and try to connect the smaller rural communities to healthcare services.
I just want to throw in, when she says she's forced to talk about it, it's because Desiree consistently doesn't mention that she's the mayor, and I'm constantly trying to get her to take pride in everything she does. So it's not a bullying situation, just to be clear. So mobile clinics, which most people aren't really familiar with. I don't know if any of you have ever been to rural America, but unless you have, specifically in the South, it's very hard to picture. This seems like a stupid thing to say, but like just how much space there is everywhere. It is impossible to get from A to B if you don't have a vehicle. Even if you do have a car, gas is expensive. A family member might be using it. It might be broken and you can't fix it. It's just like the sheer kind of magnitude of distance between things poses what is in many cases like an insurmountable barrier to care. And we know already that rural communities are less likely to get access to reproductive health care services. But that's especially in a state like Mississippi, where even if there's a provider in your town, which is rare if you live in a small community, in the state of Mississippi, pharmacists and medical professionals are able to legally refuse to provide you care if it conflicts with their beliefs. So you could have someone who's down the street from you, but that doesn't mean that you can actually get what you need. If they think that you're, unmarried and 22 and shouldn't be on birth control, you're not going to be able to get the care that you need. And the distance traveling to providers, just an example of a patient that we saw when I was first doing early focus groups in the community trying to build the program. I asked her, she lives in a small town, Shelby, Mississippi, and I asked her, if you need to go to the doctor, like, what do you do? What's kind of your game plan? She doesn't own a car. She lives below the poverty level. And she said, well, if I really have to, so she puts it off until it's kind of in absolute need, I'll get up at 6 a.m, stand at the side of the road and hitchhike my way to the nearest provider, which is around 20 miles away. But even if you wanted to walk, it's, along a major highway. And then I'll get there, I'll wait for my appointment, and then I'll kind of hang out all day until someone's going in the direction of home and get a ride that way. Because even though that clinic has what's a sliding scale, which means she pays a low amount for care, it would cost her $50 to pay someone to get her to the clinic. So she has to hitchhike when she needs, or she used to have to hitchhike when she needed it, but now we're able to go directly into the community and provide the care that they need. That means that we do go to some larger towns, but the average size of the town that we go to when you leave out the bigger cities is around 900 people. So we really focus on these small areas where the most vulnerable communities are facing these barriers to getting the care that they need. And paired with kind of the distance issue is the time issue. So people have to travel far distances to be able to get to a clinic that they can go to. They also have to take time off of work because most clinics don't have non-traditional hours. And we address that by being open on the weekends, at night, at staggered hours. Sometimes if patients can't make it to the clinic, we even have done like home visits. Like we have patients who've needed the birth control shot and they can't get it from the Department of Health either because they charge or because we just learned actually the Department of Health in one of the counties only has a nurse practitioner there 1 day a month. So if you can't make it on that one day, you're just kind of out of luck. So she hadn't had her depot shot in several months. And so we did, like with her and with another patient, kind of a home visit to make sure that they got the care that they needed. Another kind of example of that, one of the things that we do that's very effective is we partner with local like workplaces. We were just recently at a chemical factory. We've gone to, we're working on getting into catfish farms and different offices where we have arrangements with the managers where they'll let people off the line to come outside to the clinic and receive care so that they don't have to take off of work, so that they are a healthier workforce. And an example of how impactful that can be is actually our first week on the road. We were at this chemical factory, and a woman came in for a pap smear and an IUD removal. And when her blood pressure was being taken, her blood pressure was 220 over 110, which, if you're not familiar, is like very, very high, kill you high. And so we, put off getting the rest of the care and sent her immediately to the emergency room. And she had known that she had high blood pressure. She hadn't been able to go to the provider for follow-up. She hadn't been able to afford her prescription medication. And she just had been kind of letting it ride because she didn't have any other choice. And it wasn't that she didn't prioritize her health or that she didn't want care. It's just that she couldn't get it in the circumstances that she was in. And we were able to, in that case, have an extraordinary impact on her life, and then also have kind of the follow-up. And something that's worth noting in that regard is that we had, when that happened in the first week, we were also proud of ourselves for handling an emergency so smoothly, which we all did. But we thought it was going to be an anomaly. But at least a couple times a month, someone comes to the clinic and ends up having a blood pressure that high that they have to go to the ER. And it's just because these numbers are so uncontrolled. And we now, like 60% of the patients who come to our clinic have high blood pressure. Sorry. Which is relevant. I have no idea what they're trying to deliver, which is relevant mostly because, well, for many reasons, including that the rates of maternal mortality in Mississippi are incredibly high. And part of the reason for that is that people are unhealthy over the course of their lives. And so when they get pregnant, they have higher risk pregnancies, and that increases maternal mortality. So it's kind of part of why we take this all-encompassing approach to care, where we do focus on somebody's full reproductive health journey over the course of their entire lifetime. But we also incorporate elements of kind of basic primary care, because having a healthy life is essential to a healthy reproductive future. And I'll let Desiree talk a bit about kind of the barriers around cost and some of the stigma that we approach in our work.
So when we're talking about cost, that's one thing that's very important when coming to Plan A. A lot of the services that we provide, are free of charge. We do have some patients that, will come in and we'll just kind of talk about, why they don't have insurance, and they become very apologetic as to, why they're not able to, have insurance, and why they kind of need to come into the clinic. And that's not why we're there. We just want to make sure that we provide services, because being a part of the rural area and also the Mississippi Delta, I understand, when you have families that have to choose between going and, getting medication that they may need versus being able to feed their family, or going to a doctor visit where they may have a copay that they'll have to choose between paying a utility bill. And so just having to be apologetic for not having insurance or being underinsured, because we found that individuals can have insurance, but if they can't make that copayment, then again, they're less likely to actually go and render that service. And so that's another reason why Plan A is there to help, complement the services that's being provided in the community. And with complementing, if there is a provider in the community that, we can be able to provide those services, we're able to refer them, to other clinics, or if there is a services that they can't provide that we provide, we definitely have those services there. And when we're talking about some of those stigmas, there's something that's not really discussed a lot about maybe birth control, or just pregnancy altogether, because of relationship that's already being formed, or just being in a certain community and everybody kind of knowing everyone. but more than anything, just being able to, provide those services that's actually needed. So we want anyone that visits the clinic, to not be apologetic for their insurance status and to just help them to be proactive and take care of their health. We do have some health outcomes that's not where we actually want them to be. However, through education and continued access and actually bringing those services to the community, we're hoping to help decrease those health disparities and increase their access for patients in the area in which we cover.
Around 80, so we do this exit survey when people leave our clinic, and 85% of the people come in say that having the mobile clinic there increased their ability to receive care, or was care that they wouldn't have received otherwise. And that's kind of the prevailing response that we get from these towns we go to, is like, thank you for not forgetting that we need care too, because nobody's focused on these small communities. And that's how also we find word spreads throughout the community, and people will, like, recently we saw a mom who came in for a pap smear and who found out that we do free family planning and was like, oh, I have to bring my daughter in, and made an appointment for her. Or I was just down in Mississippi, and I was talking to the lovely lady who checked me in at the Hampton Inn, and she was telling me about how her daughter had who's 18, was about to have her first kid. And I asked what the game plan was for healthcare afterwards, because in Mississippi, you get kicked off of you can get Medicaid if you're pregnant, but you get kicked off of it after 2 months. So there's no opportunity for follow-up care because the state hasn't expanded Medicaid, which is a separate atrocious battle I could talk about all day. But and she, when she found out what we do, was like, oh, I'm totally going to bring my daughter there. So the need for these services is really incredible. And when people find out about us, it often becomes kind of like a family affair, where they'll come in and they'll bring other people and they'll bring their friends, because they realize that, like, this is a way that they can get care from our entire team is women from the Delta who are from the communities that they serve. And so they understand the community that we're working in. They identify, they know the folks that they're working with, but also are, because they're not from exactly the small towns, it has like confidentiality, where people are often worried if you go to a provider in your town of 200 people, that word's going to get around whatever you do. And so we are very careful to kind of work very closely with the community, but also respect those boundaries. So I know that it's sometimes hard to picture kind of what a mobile clinic looks like, because people have all kinds of different ideas, but this is our clinic, which is a truck we hired a local artist, Sam McCain, to paint the mural on the side of the truck, which kind of represents the Delta in various ways. There's like a guitar there, and it's amazing. And so it's very eye-catching when it comes to town. And as I said, it's around 210 square feet, but we fit a lot in it. So there's all the art on the walls we did a community photo contest for people to submit pictures of the Delta. So we worked really hard to involve the community in every step. So we've got 2 exam rooms. The exam room on the bottom left has a wheelchair lift, so it's accessible. Then a little lab space, and then there's also a bathroom. So it's really like an all-encompassed, all-contained, like doctor's office, basically, literally on wheels. And is able to kind of go to these small towns and provide everything we need in partnership with the community that we serve. We work with churches, we work with community centers, we work with mayors, we work with everyone who's on the ground to build trust and also be out in the community we serve. We also have a brick and mortar clinic, which I included these kind of glow up photos because I'm very proud of how we evolved. We inherited this. We didn't inherit this building. We didn't have any intention of opening a brick and mortar clinic, but the mayor of this town, Louise, Mississippi, when I was talking to him, said, oh, I have a building. Do you want it? And I couldn't say no to that. So we suddenly had a brick and mortar clinic. And it was previously a daycare, which is where you can see kind of some of the more unique art lying around on the walls. And we turned it into a fully functional office, which is just an example of how, when you're a small, nimble organization, you kind of take the resources you can and run with them. So that has 2 exam rooms, an intake room, which also is an exam room, and a lab. And actually now we also have a pharmacy. And we're working on expanding services both there and in the mobile unit, especially in the post-Roe world, where we're adding ultrasounds, which can be for dating, which can be post-abortion or miscarriage care, or prenatal care if people are carrying to term. We're adding, so that kind of follow-up. We also are added these care packages that we do where we'll mail anywhere in the state emergency contraception, pregnancy tests, and condoms, which also we hand out on the mobile clinic. All of these services are totally free. And we are hopefully going to get a grant to add pediatric care, limited pediatric care in the brick and mortar clinic, which is really important because something that happens a lot in the community is, as Desiree was talking about with cost and also just related to time, is people will prioritize the expense and the difficulty of getting care for their kids, but they won't do the same for themselves, which goes, well, that's our team celebrating our first anniversary. But it goes to this quote where it's saying, you know, they put off things for themselves. And so one of the reasons that we're adding pediatrics is both because it's important and you know, kids need care, but also because it'll draw the parents in. So we're going to do like moms and dads and babies days, where the parents will bring in the kid because we know that they'll go the extra mile to do that. And we'll say, you know, while you're here, let's talk to you about your pap smear or family planning or anything along those lines to make sure that people are really getting the care that they need. And the Mississippi program's been up and running for a year and a half now. And the team is doing absolutely incredible work. And so we started looking at, and with Desiree now to kind of helm things on the ground, we started looking at other states and how can we expand this model to other rural areas, because Mississippi, you know, gets a lot of attention for its restrictive policies and for its horrible healthcare outcomes and for various other things. But the reality is that it's not, the Mississippi Delta, which is the poorest region of the poorest state in the country, is not an anomaly. Like, this is the barriers that are faced in these communities are also faced in rural, I mean, in some areas of rural New York and you know, just kind of all over the place. And so we've started looking at expanding into other states in the deep South. We're looking right now at Georgia and then Alabama to look at these rural areas and prove that the model works, and to encourage other mobile clinics based on our success to add reproductive healthcare services, to encourage other clinics to add mobile services, to really create a scalable model that not just we will manage in other states, but that other people can as well. Because we, you know, we're a small organization, we can't take on the world, but we can do what we do in our communities very effectively and bring people along so that they understand that reproductive mobile health is like a wildly effective way of making sure that people, especially our most vulnerable communities who don't have access to the essential services that they need to make decisions about their future, have access to the care that they need. And yeah, that's kind of big picture what we do, just doing our best to kind of work within the policies and systems we have and the restrictions that people are facing to make sure that cost and distance and time and stigma are never a reason that people are putting off the care that they need. And that's it. Question? Desiree, do you have anything to add? I'm sorry.
No, I think you added at the end. I didn't know that you were going to say about the expansion part, so I was ready to jump in with that. So I know that there was a question about how do you get the employers buy-in for the services from the chat. There was a question.
Yes.
How do you convince employers to give you access to their workforce? Do they seek you out? And I think I could kind of answer that, and Caroline can add as well, because when they first started. So a lot of the employers here, believe it or not, has like nurses within their actual workforce. And the nurses actually have days where they provide educational information and also outreach and screenings. And employers want to make sure that their employees are healthy And instead of like the time and the cost of them, not being at work, actually having services come to them, they're definitely on board with it. And they do actually reach out to us to come into their clinic. And we also reach out to them to tell them what services we have available.
In the beginning, it was like pulling teeth getting into places because we're a total sight unseen, right? Like no one's ever heard of Plan A. Certainly no one knew who I was. And like, we were building it, and our core team did an amazing job of getting the word out so that the community is now familiar with us and knows us, and now people come to us, which both makes our job a lot easier, but also shows kind of the progress that we had in that first year. And then going to the other questions, I would say to Ms. Jones, like the question of it being available in other states pairs very well with Kitty's question about how much does it cost, which is that our expansion into other states is like purely limited by money. We have the passion, we have the capacity, we just need the resources. So it costs around, we're pegging it at around $800,000 to launch new programs, because that's the cost of both the physical mobile unit and I'll get to that in a second. That's the cost of the physical mobile unit and a year's worth of program expenses. And we want to make sure that while we've successfully built a sustainable program in Mississippi, we don't expand so fast that we run out of money in any location. I don't want to spend the first year of a new program panicking about running out of cash. So we won't launch a new program until we have those resources in place. Unlike in Mississippi, where I was building this for the first 2.5 years by myself. And every time I walked into a room, I would say, this is a game-changing plan. Everything's going to be amazing. I don't have the money yet, so I don't know when it's going to happen, but I promise it will. And that was a much harder conversation than saying, I have the cash, I have the clinic, we're coming soon. So that's kind of what we're working on, is that $800K. Right now we're looking at Georgia, with Alabama actually is close behind, mostly because a woman from Alabama reached out to us right after Roe fell while we were looking at Georgia and said, we basically what this message says, like, we need this in Alabama. She actually said, well, if I can get you the money, will you open it? And I was like, yes, please. And so she's working on that, but we're trying to raise the money to be able to open in the next year and a half to 2 years, the 2 programs in Alabama and Georgia. Although if somebody dropped $2 million in my lap right now, which I'd be delighted by, we would be able to open that on a faster timeline because we'd be able to hire more staff. But yeah.
Hey, can I jump in? I just want to, it's Kim Charles, and some of us went down to visit Plan A a few months ago and see it firsthand. And first of all, Desiree, I don't know if you remember me, but hey, I'm so happy to see you. I'd go anywhere and Zoom into anything to hear Caroline, but if I'd known Desiree was going to be on today, that's a whole nother level of celebrity. So it's so nice to see you. And I just want to say that the pictures don't do justice to what this clinic looks like. It's nicer than any clinic or any doctor's office I've been in. It's pristine, it's beautiful, it's so well appointed. And I think, especially with the Big Tent group, I just want to throw in, the people on this call and the people with Big Tent know how important networks are and how one thing leads to another thing, leads to another thing. And that's what we really saw with Plan A in Mississippi. The community credibility with having, people who live in the community as trusted sources of healthcare is just incredible. And then we met with nonprofit leaders and other activists in the area who have come to know and trust and really believe in the work of Plan A too. And that just builds on itself. It's incredibly powerful in that community. And I, for one, am super excited about what you guys are going to do in Georgia. But anyway, hey, Desiree.
Hi, it's good to see you again.
Thank you, Kim. I really appreciate those words. Yeah, it was amazing to be able to show folks from New York this program, because I think it's very hard to picture unless you're down there. So we were really grateful to you guys for coming down, and I'm glad I was able to share pictures with everyone of our work.
Caroline,
Any other questions? Oh, sorry.
I have a quick question. You've talked about the small communities and how it's sometimes hard to visualize the space between communities. So how many miles have you logged on the mobile clinic in a year?
Our first year, we logged, I think, 7,200 miles. I want to say it's probably more than that. I could tell you, it's actually Antoinette, who's our community health worker, who was originally a long haul trucker, who we trained as a community health worker. Yeah, she's wonderful. She sends it to me every month, but I haven't looked at the latest month one yet. But it's usually our truck is based in a town called Greenville, and it travels between, like, sometimes up to, I would say, like 100, 125 miles away from that core spot, depending on where we're providing services. And so it travels a really far distance. And sometimes, you know, we'll travel really far to a town of 200 people and we'll see 10 people, which is a significant portion of the population, but only like 2 or 3 of those will need family planning or reproductive health services. And so statistically, you're kind of like, wow, we traveled a far distance for that small group. But the reality is that those are the people who have the most difficulty accessing care. So that's where our like biggest impact is traveling that far distance for other people who can't. You can't, you know, it's incredibly important, obviously, to offer these services in urban communities. But when you're in rural, you know, Sunflower or Shelby or Louise, you can't just call an Uber and get to the nearest clinic. Like, if you have the money, like, having money won't solve the problem always. So, so yeah, so we travel a lot. Antoinette does a lot of driving in that rig. But
you take walk-ups if people's.
Yeah, so most of our patients are walk-ins. We do sometimes when we're doing specialty services, it's not, like, for example, January is it's not January, it's September. Sorry, I lied a little bit. September is Sickle Cell Awareness Month, and so we added we're doing free sickle cell screenings this month. And because those are like a little time consuming and kind of complicated, we're doing that by appointment only. And when we do free mammogram and pap smear events, we do those by appointment only. But I would say probably like 90% of our days are walk-ins.
How do you find, is it hard to find places to park? Like, does any of the sort of stigma of, do you feel that when in any of the communities, you were talking about how people in Mississippi, providers can deny care if it's a conflict. Do you feel any of that tension when you're deciding where to stop?
So the team has done a really incredible job of making sure that, so we message ourselves as around the full spectrum of reproductive health, and we added primary care screenings because what the community said when I was doing these focus groups in the first year was, if you only offer reproductive and sexual health services, you'll be known as the sex bus, and nobody will go inside because everybody's going to know your business the second you walk on.
Oh, that's interesting.
So we worked really hard. Yes, exactly. So we worked really hard to message ourselves more broadly. And the team does a lot of work with pastors and community leaders and trusted messengers to make sure that that comes across, and to make sure that that what we do is rooted within them. And we've done, we haven't really come into it. Sorry, Desiree, I'm used to doing these things alone, and I totally forgot that you can answer these questions. Do you want to take this one about like the work with the community?
No, you're fine. No, you're fine.
So do you have like any thoughts on, you know, how we work with pastors or how the community's been receptive around these issues?
Okay, yeah, so we do work with pastors in the community, and we're able to provide some of the those primary screenings. And they are very important because even when you're talking about any type of birth control method, you have to make sure that a patient actually has the correct blood pressure, also looking at just how they can be healthy overall, even in terms of with the prenatal or planned pregnancy. So we're able to provide those resources. And Caroline didn't mention this, but I also wanted to talk about how our community health workers, our team, Caroline, has been amazing beyond the actual mobile clinic. Like, we're usually on the road about 3 days a week. And then the other 2 days that we're, at the office, we're actually connecting to resources. We're connecting our patients to additional resources. So whether that be some type of food insecurity or, access to housing or trying to get medication, or if it's something that they need in terms of social and mental health. I mean, it goes beyond the care that we sometimes provide on the actual mobile clinic, because we want to make sure that anyone that comes there understand that this is like a family environment, and we want to make sure that we are caring for their well-being overall. And I promise you, if it's something that the community needs, and even if we're not offering it, Caroline is definitely going to look into or try to find those resources so that we can provide that service, whether it's something that we're going to add to our service or is actually connecting to someone that provides it outside of this. So she's very great about connecting and making sure that we're providing resources and meeting the entire person.
Do you all pair with any voter registration? Do you make sure people are registered to vote when they come in?
Yes, we do. We actually have the forms on the mobile clinic as well as in our brick and mortar. And they're able to, yes. So they're able to actually complete those forms. If they can't, submit them, they can leave them and we'll actually get them mailed. So yes.
That's fantastic. So I'm curious how you came up with the name Plan A. I mean, it's sort of obvious, but
yeah, I mean, it was honestly coming up with the name was like the most challenging part of incorporating. We spent a lot of time kicking around various names. A lot of them were very women focused, which was something that we wanted to kind of avoid, just because we did want to be all encompassing around all genders, and also because of the stigma issue, we wanted to make sure that that it was, broader. Then I mean, Plan A, Plan B. I've always been very focused on, like, I went to medical school, but I don't practice, and I kind of viewed the most effective thing I could do is kind of making sure that people don't need a healthcare system that fails them, and having that kind of preventive care, which is the Plan A. So it kind of, play on words, preventive, like birth control is preventive of broad things. I don't know. I amused myself. It was like 4 a.m. when I came up with it.
It's actually wonderful because it helps. It's not only good for the patient themselves, but it also helps position you within the community as that broader a source of care. Very broad, more
so. Terrible SEO though. Big mistake with the name on the SEO. Very hard to find Plan A. It turns out it's a very popular term.
Yes, yeah, I did find that. So when you choose, I'm assuming that the mobile clinic can only stay within Mississippi. Is it only licensed to serve within the state?
Yeah. So yes, although if our nurse practitioner was licensed elsewhere, we'd be able to go to some other areas, but we would have to pursue licensing and other stuff, but in other states. But we're going to get like a new unit for each additional state. So we've gone to other areas in Mississippi with this one, but we're going to get new ones, which also, like I said, for example, that it costs $800,000 for a new program, which includes $400,000 for a new mobile clinic. But if somebody knows someone at Ford or Chevy or who owns a dealership and wants to give us a pickup truck for free, that saves me $70,000, and we only need to raise $730,000. So, it's also about like things like that that we're able to kind of expand to other areas with these new resources, both in kind and cash.
Does the nurse practitioner travel with the truck, or do you have, it sounded like you had also staff in each community, like local?
So we're working on building a team of community health advocates, which is like individual people in the small towns to help us get the word out and do health education. But our team travels with the truck. So Antoinette drives it, and then the team drives their own cars. But they go from spot to spot meeting, and we have some additional folks who work like in the brick and mortar Louise clinic, or who fill in on different days. But our core team really travels everywhere together. And we're also working on adding now telehealth services so that we can kind of expand our reach, especially because we're a trusted group for people to receive reproductive health care, to know that we will treat them no matter why they're coming to the clinic, with confidentiality and respect. And so we wanted to kind of expand that availability to folks statewide in a environment where you really don't know who you can trust when you're looking for reproductive health care. Is my very diplomatic way of putting the situation.
Well, I read an article that sometimes on Google Maps, if you put in like, reproductive clinic or whatever, it will send you to the opposite. Have you come across anything like that, or are you?
Yeah, I mean, it's funny. Funny is very much the wrong word, but I actually just saw a billboard when I was driving through Mississippi for a crisis pregnancy center, and they're super deceptive. It's like, pregnant, need help, like come to whatever. And it seems like they'd help you no matter what you need, but the reality is that is very much not the case. And so yeah, I mean, crisis pregnancy centers come up a lot. We also don't know how abortion will be treated moving forward. So we don't know, will providers be turning people in? Will they be willing to, do an ultrasound for people? Will they track people? How are all these things happening? And we think very closely about what kind of records we keep, what kind of conversations we have with people. We are a Title X funded clinic, which means that this means two things that are beneficial currently. One is that we can see people under the age of 18 without parental consent, which opens up a lot of doors for people in an area where they might not have a conversation. And the other is that it's in our contract with the federal government that we are mandated to do comprehensive options counseling with our patients. So no matter what happens with state law around those conversations, we got a $70,000 grant that says we have to do that or they will take the money back. I'm very much not giving that money back. So we are free and clear to be having those conversations with people. And in terms of what we do post the options counseling, we are, keeping a close eye on things, but making sure that patients get whatever care they want for their own futures.
Do you all pair up with any universities or academic, schools or?
So yes, we do. Very exciting. That's one of our newest projects where we're actually partnering with our local universities and community colleges, and we will go to the campuses once per month, unless they have any type of special screening days or healthcare days, and we're going to provide the services to the students and staff there. We're really looking forward to kicking off this college campus tour, which will begin on, I guess, week after next, the end of September. We're going to visit one of the colleges in Coahoma County. So yes, we are partnering with them. And in addition, we will have college advocates, and those will be kind of similar to our community advocates, where they will help with putting the word out on the campus about the services that we offer, as well as providing opportunities to educate. So please be on the lookout for the college tour hosted by Plan A Health.
That's fantastic. What a great idea. What a great idea.
Sorry, I was just gonna say, like, yeah, the college stops are just like crazy busy whenever we do them. Like, we were doing this interview with ABC News where they came to film us on Delta State University, and we were all set up and we were supposed to close the clinic at 3 o'clock. The interview was supposed to happen at 4. So we were wrapping up at 3, and then just like patient after patient after patient kept coming because the need was so great and people were so excited for the clinic that essentially, like, I think the interview started at like 5:30. I had to keep apologizing because every time we would get ready, another person would come. And one of the things about our team is that, you know, we set the clock of what the hours are, and it always, when there's people coming, it ends up running over because they're not going to turn anyone away. So the college campuses have been really really effective places for us to reach large groups.
That's fantastic. So we're just, does anybody else have any questions before I wrap things up soon from our audience? I have a one question in particular that I'm curious about is what resources would you recommend for us to look into to learn more about the state of healthcare in rural communities? Books, people, podcasts.
Yeah, I can. There's a bunch of articles on this that I can I can send you to kind of share with people. But in terms of broader kind of the reproductive justice issues, there's a book called Killing Black Bodies that is speaks very clearly and effectively about the challenges that have been faced. It's by a woman named Dorothy Roberts. There's also a study that came out recently, or an article, again, I can send it, but it's called like Racism Runs Through It, and it's all about the reproductive health experiences in the rural South. There has been one of the things that happened during COVID was that there is a lot of attention given to these barriers. So there's a ton of articles about it, really. But I would start with that, and then also this study that came out recently in Health Affairs, or this article about racism and reproductive health care in the Deep South. And yeah, I mean, I think I would just encourage everyone to think about the impact that small programs like ours, these community-based health programs that really do the work on the ground, have in these spaces, and really seek them out. Like, what, either support Plan A, which is great, we'd love your support. Like, it's our team is doing incredible work, and our ability to do it more and in other areas is purely limited by funding. So we're eager for that. But if it's not Plan A and it's something else, really seek out these small programs that are doing the work on the ground with the community. That can have an outsized impact with any amount of funding that they get. It's really time to be investing in those programs and building them up. And then also, I would say, this has nothing to do with the question you asked, but while I'm talking, that like, if nonprofits benefit from two things, it's money, obviously, and people's time. So if there's a skill, if you, like I am, and like Desiree, and I assume like everyone on this call, are like as furious about the state of everything as you are, and there is a skill that you want to put to use, you're a good writer, you do graphic design, you're a lawyer, you network effectively, whatever it is, like either we or another nonprofit can use those skills. So I would encourage people, like, if you're looking for a way to channel your rage or your grief or whatever emotion you're feeling right now, like, there are very effective ways to do that. And I am happy to point you at a way to do that with Plan A, or to point you to another organization that can use that skill. And, you know, it's really people donating both their resources and their time that help small programs like ours thrive. So, yeah.
Well, you all, Caroline and Desiree, have given us a prime example of how to stay positive and have a positive influence, person by person, community by community, and make a difference. And thank you so much for all your team does. I know Vanessa has added some links into the chat for some articles and for Plan A. And also, please help us spread the word about all the good work that you do. And most importantly, tomorrow night, I hope you all join us for Cecile Richards, who's coming to further this conversation about these important issues that affect women in particular in our communities. So look forward to seeing you there. Thank you so much, everyone.
Thank you for having us.